integrase inhibitors, I think with some data coming in that, you know, it could potentially impact dolutegravir use.
Hi, everybody. To be here and share a few thoughts with you. Yeah, I agree that it might matter. I still think we need more data to actually assess the clinical impact of that. So I know it starts to be very complex. So we have to weight all the single viral and personal and PK issues in the same patient. So I don't think we have a clear answer here.
Okay. Dr. Venter, any thoughts on that particular question?
So I think with all the resistance stuff, increasingly the devil's in clinical detail. Just a paper that came out, we had out in AIDS looking at our advanced study, we demonstrated actual incredibly high resuppression rates with dolutegravir, even in the presence of various forms of resistance. But to take one step back, we even showed very high levels of resuppression with efavirenz, despite with high levels of NRTI resistance. So I'm actually quite reassured by these studies that we just need to wait and see. I'm much less alarmed than I would have been, say, 10 years ago.
Right. Thanks so much. There is another question that's come through from the participants, which might be going a little bit further away from the topic that we were discussing tonight, but I thought, you know, I'll put it out there. One of the participants asked what technologies exist to quantitatively measure viral reservoirs, and, you know, how do we evaluate the effectiveness of therapies that are aimed at reducing viral reservoirs, you know, and sort of moving towards cure research and so on. Dr. Venter, do you want to take that first before Dr. Calcagno?
It's way above my pay grade, I'm afraid, in terms of the basic sciences of this. We have started to do some work looking at characterizing the reservoirs, particularly the more difficult to reach ones. You know, in South Africa, we're very lucky because we have a combination of large numbers of patients, the sad reality that we have a lot of trauma patients. So we're able to biopsy these reservoirs in people who are suppressed in fresh tissue. So we're trying to take that forward to try and characterize them. But in terms of the actual quantitation, I think you better talk to some of the virologists.
So I may just, I think the most used ones are the total DNA in PBMCs. We know that's not really a very specific measure. And probably would need to measure the replication competent virus. That is something really more complicated. And my focus in the last year is the CNS. And recent data suggested that if you take out a lot of CSF and you get the cells there, you see that most of them are enriched with DNA. So it might be that in certain tissues and organs, you find the reservoir different from the like, systemic reservoir. But I think at this time point, we don't have a very, very useful marker in clinical practice.
So yeah, there are issues with this measurement because if you look at total DNA, as Andrea said, a lot of the virus is probably non-replicative that's there. People have looked at gut specimens, rectal specimens, all sorts of lymph nodes to look at reservoir. But to say that you can really measure the reservoir from taking a blood sample is difficult. And in fact, there's been lots of data looking at over time, giving people antiretrovirals and seeing what's happened to the reservoir. And it's a technology, I think, has shown very little difference. Because some of the things that we're interested in is that it's, you know, if you're on a undetectable for more than 6 years from some of the studies, and then you reintroduce antiretrovirals that you may have been resistant to back there, and it comes to what François' point was about treating patients even with resistant mutations, they seem to have done quite well. So, and people say, oh, it's because the reservoirs are diminished, especially those ones which code for resistant virus. So I think that we're still not there with very accurate reservoir measurements and exactly what they mean, but we're getting there, I think.
Okay, I mean, yeah, personally, I kind of echo Dr. Venter's, it's kind of above my pay grade, and it's not something that we look at really clinically at this point, but I think it's exciting looking at the advancements that have gone on. There's been another question that's come in, a little bit more clinical, and rather succinctly phrased: DTG plus 3TC plus AZT, okay? Question mark. So Comivir, dolutegravir.
I must say, I used to be a fan of the thymidine analogs, and I'm a reborn anti-fan. I think that they're so toxic. We're seeing quite a lot of, I think we've all been so betrayed by D4T and the long-term side effects. But even with AZT, we're seeing these long-term survivors with the most terrible lipoatrophy. So I kind of, AZT is a terrible grudge match. And I think there's probably going to be some data coming out in the next few weeks and months actually demonstrating, just that we can do even more without it. So in an era of dual therapy and an era of lots of other options, we use it in second line routinely at the moment. We're hoping in the future to have data which will suggest that we can just recycle it to tenofovir. But I'm not a fan of AZT anymore.
No, and I mean, if you're not resistant to 3TC, then DTG 3TC will do the job, and I would avoid AZT as much as possible. It is true, though, that most dual therapy have used nucleoside analogs, either non-nucleoside or nucleoside, to be really effective. And to, because if you look at putting together an integrase plus a protease, they don't seem to work very well. You always need to put some nucleoside analog, either a non-nuke or a nuke together, but that nuke was not AZT in my book.
Yeah, I mean, in Singapore at least, AZT is still used by some patients, primarily because of historical reasons and just a perhaps understandable reluctance to shift away from something that saved their lives many years ago, and it's been a struggle. But one thing is, definitely the reduction in the dosing frequency by that's one of the strategies that we have used. I maybe want to open up a question of my own to the panel, and what do the panelists feel about the use of integrase inhibitor-based combinations, especially in progressively aging populations that we are seeing, and really being as a marker of success of antiretroviral therapy. I think that our patient cohorts are getting older.
I can start if you. So,
okay. Yes.
We're having a large cohort in Italy with more than 1,000 patients aged above 65, and we're trying to take a look at some of these questions. And one of the focuses is polypharmacy and drug-drug interactions. So, as far as we know now, these are the drugs that the least burden of drug interaction and with other compounds our patients are taking. So I think at this time point, those are the drugs we want to go for in this population.
Yeah, we use a lot of integrases in this population, but we try not to use any boosted integrase because of the drug interactions from the booster on people who are elderly who have that. The competitor, I think, for integrase in this population, which may or may not be available to you, is doravirine, but you must make sure you've not got resistant mutations to it before, and probably it's challenging to use it in your situation, François, where there's been a lot of ephedrine use in the past.
So correct. We have a lot of circulating NRTI resistance. It's as high as 20% in people restarting first-line therapy. In terms of tolerance to dolutegravir, I think that it's been incredibly well tolerated in our large public sector programs. We've had several million people transition across in the last 14 or 15 months. And as I said, from a short-term side effect profile, the thing that people are grappling with is the weight gain. And there's a huge debate, as you probably all know, as to whether that weight gain is actually just simply that dolutegravir is better tolerated and people are just returning to the normal trajectory that they normally would gain weight, which is increasingly what I think is happening. But it is distressing for people. Otherwise, we have not actually seen a single consistent side effect. We haven't seen the insomnia, we haven't seen the CNS side effects reported particularly from European countries. So I think this class of drugs are very, very well tolerated. We're looking forward to assessing doravirine and islatravir and the new capsid inhibitors, seeing if perhaps they add something to that. But it's really is a wait and see situation.
They've really set the bar very high, the integrase inhibitors in this population. They really have.
Okay.
François, I also saw that in the advanced study, there was absolutely no insomnia and no neuropsychiatric side effect. It was almost zero.
It was really it was annoying almost. We powered the whole study around insomnia, and the patients at baseline slept 8 hours a day, and at the end of the study slept 8 hours a day. I think the study team was really resentful actually at the end of it all. They slept better than we did.
And in these naive studies, especially when you start therapy, people do get insomnia at the beginning because of the worry of starting antiretroviral therapy and what you've all been speaking about adhering to the therapy, remembering to take the drugs, being fearful that something might happen. So there's so some of this insomnia in the first few weeks could be related to some anxiety, which needs to be teased out of some of the data.
That's great. I guess another question is, staying on the topic of integrase inhibitors, but specifically with regards to long-acting and perhaps injectable ones. It's a slightly more distant prospect here in Singapore. We tend to lag behind US FDA approvals by about 2 or 3 years. But where do you see the role of these long-actings factoring into patients, especially with regards to adherence and the implications of adherence? Anyone? Calcagno, Dr. Calcagno.
Okay, I'm not shy. So we had a lot of discussion if those drugs should be proposed to everyone or only to those requiring the drugs or those with adherence issues. So I think we still don't know. We know that those taking the drugs in the trials were really happy with that and were really adherent, that there was not much of an issue. So we'll probably start also because we need to remodulate our outpatient clinic because of the injection and etc. We'll start with a few patients with a long-lasting suppression that, for example, they want to switch to intramuscular. That's the start. And we'll see over time if many patients will require the drug. So we have to remodulate. We think we still are missing the data that probably will come from the US in very hard to reach population, such as those in Baltimore, to see if there's something there with patients with adherence issues, what's going on with that.
Yeah, I'm with Andrea on this one. I think that the immediate population that's going to benefit are those actually paradoxically are the most adherent. What we're seeing in South Africa, which I think is happening in other countries, is that patients are far more enthusiastic about this than healthcare workers. As I say in my presentation, our experience with injectable contraception is this idea of breakthrough pregnancies because people just forget to come forward, rather than the routine of everyday tablet taking, remembering to have to come in every 2 or 3 months for an injection is going to pose systemic challenges. So I'm still trying to get my head around exactly which populations we're going to be able to provide this to.
Yeah, I think we have to follow the data. And as Andrea and François said, the first data, which we've got most about, is the switch studies in people who really want to go on an injection. They volunteered for a trial, so they must have wanted that. We do have some induction maintenance data now. So that's another group that we could consider, but watch them carefully. But, injections are also going to raise adherence issues because if you don't come back, you have to be found and given your injection before you get, as Andrea was talking about, this long pharmacokinetic tail. And if you get viral rebound, we create an issue for ourselves in terms of potential resistance. So it's another thing we're going to challenge ourselves with.
François, Dr. Volta, one of the points that you sort of brought up early in your presentation, you had a slide talking about late presentation, and it's a huge problem in parts of Asia, of the Asia Pacific. In Singapore, definitely, more than half of our new cases that are reported every year present with a CD4 count of less than 200 or with an AIDS presenting illness. I was just curious about what the link you were drawing with adherence and sort of long-term success with treatment was.
It's possibly different to many of the Asian countries because South Africa, our HIV prevalence is so high,
right.
As a cause of both illness and of death. It's still, it's been front and center of everyone's mind for 20 years. There's hardly a South African that hasn't had some form of counseling about HIV testing. The testing rates in the country are incredibly high, and yet we still have this stubborn population of patients who just come in with these incredibly low CD4 counts. And where we have had studies looking at them, they demonstrate much lower levels of adherence. They fall off therapy. So it's not about side effects, at this stage. It's all about denial, some sort of psychological impact on it. And trying to understand that, I think, is probably one of the biggest hurdles we actually have. The numbers of patients presenting with cryptococcal meningitis, which is a great proxy, has barely changed in the last 16, 17 years, despite widespread testing, widespread freely available antiretroviral therapy. So I think there's going to have to be a different model for that class of patients. I am struck when I haven't looked at Asian data, but when I looked at some of the European data and some of the other African data, at how consistent that seems to be across all countries, that, this kind of late presenter group is almost refractory to widespread HIV. Our average CD4 count has gone up, but at the same time, the percentage of people presenting with a CD4 count below 200 has remained exactly the same, suggesting there's something more than testing programs are going to solve this.
Okay. Thanks so much for that. I've been told that we need to round up and wrap up the discussion. So I thank everyone, Dr. Pozniak, Dr. Calcagno, Dr. Venter, for your points.